Thank you so much for the kind invitation to participate in this venue. I'm a pediatric neurologist. I feel intrigued among experts in pediatric cardiology and cardiosurgery, so I'm going to be the odd person in the room talking about neurodevelopmental data in those kiddos. So first, a little bit of background. CHD is the most common birth defect, affecting approximately 1% of all live births. And about a third of these kids will require surgical intervention during the first year of life. Following improvements in medical and surgical care, childhood mortality from CHD has decreased in the last 30 years, with the most notable decreases in kids with transposition of the great arteries, complete atrioventricular canal, and single ventricle physiology kids. These are Kaplan-Meier curves published from a national cohort in Sweden. And we can see that, stratified by birth decades, there is a striking decrease in the childhood mortality in kids with CHD. There is still a decrease in survival within the first 4 years, but in the last 1 decade, we have not yet a reflection of the advances of advanced cardiovascular monitoring, reflecting that into the survival. So it seems like it has been stable over the past 10 years. Regardless, this leads to the conclusion that there is an increased number of patients with CHD reaching to adulthood, and thus there are long-term comorbidities with a CHD, including associated neurodevelopmental concerns that are increasingly important and need to be addressed. And that led to this AHA scientific statement published in Circulation 2012, which has been endorsed by the American Academy of Pediatrics. So essentially, this writing group looked at all the literature available at that point, and they formulated a guideline to show to the clinicians what needs to be done to these kids after they have survived through infancy with a CHD. And this is the guideline that has been formulated. First, we need to stratify the risk of these kids of having a neurodevelopmental problem. And these are neonates or infants requiring open heart surgery, cyanotic and acyanotic types, children with other cyanotic heart lesions not requiring open heart surgery during the neonatal or infant period, and any combination of CHD and the following comorbidities: prematurity, developmental delay, suspected genetic abnormality or another syndrome, a history of mechanical support, heart transplantation, cardiopulmonary resuscitation at any point, prolonged hospitalization, perioperative seizures, and any significant abnormalities on neuroimaging or microcephaly. If we have these high-risk kids, then we refer for medical and developmental evaluation, and we refer these kids for early intervention services. If these kids do not meet criteria, then we do the regular follow-up at 9, 18, 24, 30, or 48 months old, and we administer the appropriate screening tools, and then we refer as appropriate. This is all in 2012. So what happens 10 years after? 10 years after, the committee reunited and they saw how is the literature at this point. Are these guidelines implemented? To what extent? What is the etiology, and what are the factors that predispose individuals with CHD to neurodevelopmental problems? What are the challenges that we have to face in order to provide the optimum outcome? And this is a paper that has been published just in March 2023. First, what about the etiology and the risk factors for neurodevelopmental delay in these kids? In terms of time frame, we can classify these factors as a prenatal period, during the neonatal transition, perioperatively, postoperatively, and across the lifespan. Starting with genetic abnormalities and CHD. To date, it has been shown that approximately 40% of familial CHD, 20% of sporadic CHD, 20% of CHD with extracardiac congenital abnormalities have an identifiable genetic etiology. These are trisomy 21 babies, kids who have Williams syndrome, 20q11 deletion. These are all frequently associated with alterations of the heart and the brain health. Also, there is marked overlap between deleterious de novo mutations and previously reported mutations associated with neurodevelopmental disorders. What about in utero hemodynamics? These kids have delayed cortical development. The gyration of the cortex is a dynamic process throughout pregnancy and shortly after birth. And we know from data from the hypoplastic left heart syndrome kids that these kids have a delayed gyration indices and also delayed surface brain area compared to normal kids. We know from studies from fetal imaging that they have disturbance of fetal cerebral blood flow and also other structural abnormalities, such as they are prone to stroke, hemorrhage, white matter injuries. So it's more that we want to say that these kids have a congenital heart disease and also congenital brain disease. And it is not surprising that half of these newborns at birth somehow have some sort of brain injury. We have decreased the cerebral volumes that is reflected to microcephaly. And also there is abnormal placental structure. After birth, it has long been recognized that the neurological status of newborns with complex CHD is frequently abnormal prior to open heart surgery, including tone abnormalities, abnormal posturing, weak cry, poor coordination of suck, swallow, and breathing. We know that the cerebral blood flow and oxygen content continue to be abnormal before, and sometimes even after medical or surgical intervention in infants with complex CHD. And we have additional risk factors for NT problems, such as low cardiac output, diastolic still in association with a PDA or other form of aortopulmonary shunt, decreased pulmonary perfusion or mixing between the systemic and the pulmonary venous return. Many infants with CHD will require some form of curative or palliative cardiac intervention, including cardiac surgery, and cardiac surgery frequently requires cardiopulmonary bypass and at times deep hypothermic circulatory arrest, which expose the brain to a period of global cerebral hypoperfusion followed by reperfusion injury. And both of these modalities lead to a host of physiologic abnormalities affecting brain tissue, oxygenation on top of exposure to sedatives and anesthetics with potential effects in the developing brain. And it is thanks in large part to the Boston circulatory arrest studies that have been conducted in the 80s and 90s that we have made advances to our CBB techniques and times in order to lower them, because we know that longer CBB times are a risk factor for deficits in cognitive, language, and motor domains for both two-ventricle and single-ventricle patients. After cardiac surgery, children with CHD are vulnerable to further brain injury due to low cardiac output, hypoxemia. There is a chance of postoperative cardiac arrest, and we know from data that there can be serious complications to other organs. For example, there is a study reporting on the acute kidney injury related to postoperative cardiac arrest and the risk for neurodevelopmental delay afterwards. But also across the lifespan, we need to pay attention to psychosocial and environmental stressors. Kids with CHD are separated from their families for a long period of time. We have interruption of this family bonding experience. We have long hospital stays. And also we have to deal with other variables, such as race, ethnicity, and socioeconomic status that can predict ND outcomes. And in this study, we have clear correlation between the fine motor skill and problem-solving skill development related to the socioeconomic status of the mothers, their neighborhood, and their level of education. So what are the neurodevelopmental outcomes that we assess? This is a battery of different skills: learning and memory, attention and executive function, academic functioning, intellectual functioning, adaptive skills, motor skills, speech and language, and psychosocial functioning. Motor delays occur in about 1/3 of all children with CHD, and these delays involve fine and gross motor skills. Severe motor impairments are most prevalent in the younger CHD population, but are present throughout childhood and adolescence. In school-age children, problems related to visual motor and visual motor integration skills are frequently reflected to the difficulties in handwriting. Similar to other neurocognitive domains, we know that kids that have cyanotic types or single ventricle physiology appear to be more impacted by in their development. We know for kids that have CHD and cyanotic types, they have difficulty in oral feeding adaptation, and this can reflect to their speech and language skills. Moving forward, as children with CHD get older, attention and executive functioning impairments are among the most reported areas of concern. Executive functioning is a complex construct that includes cognitive and behavioral skills associated with goal thinking, planning, working memory, and these have all been evaluated through different tools, and we know again that single ventricle physiology kids perform worse than others. Attention problems include difficulties with divided attention and conflict monitoring, as well as decreased ability to maintain alertness and vigilance in school-age children. And we know when we had to compare CHD compared to ADHD-diagnosed kids and controls, the CHD kids were more like ADHD children during school. Larger domains of neurodevelopment also need to be monitored. For example, intellectual functioning. We know that intellectual content in kids with CHD appears to be average or below average. Academic functioning, these are kids that might need to have tutoring at class, maybe repeat a class, or have an IEP or a 504 in certain countries. Adaptive functioning, these are kids that perform worse than their peers in their expected developmental stage. Social, emotional and behavioral concerns, these are kids that have more anxiety, there is more depression, they are more aggressive. And finally, about autism spectrum disorder, there is one study reported that in 100 kids with CHD that were school age, the prevalence of autism spectrum disorder was around 5%, while the general prevalence in the United States is about 1%. So what can we do? What is the neurodevelopmental evaluation done where and by whom? So most of the times, this neurodevelopmental evaluation has been done in the school setting by school nurses. And in other countries, it has been done by formal cardiac neurodevelopmental follow-up programs in the hospital. But there is a great variety as to what to administer and at what stage. And generally, we have two main groups between birth and 5 years of age. And you can see there is a large variety of tests. Some of them have been done routinely, other tests are done sometimes, and other tests are done in school age. In general, these kids are more closely monitored from birth to 5 years of age, and rather than in school age. In terms of the neonatal period, there is a neonatal ND evaluation in about 64% of the times. And the neonatal brain MRI done in the context of hospitalization is done only in 23%. So this need to further define the neurodevelopmental evaluation has led to this cardiac neurodevelopmental outcome collaborative. This comprises a lot of hospitals in North America and Europe. And the goal is to the mission is to determine and implement best practices and psychosocial services for individuals affected by CHD. And these are the levels of how to monitor these kids from birth to 5 years. First, after hospital discharge, we need a neurology consultation, monitor the growth of the patient. There is an assessment for early intervention services, the preschool readiness, and after that, the school readiness of the kid. After the age of 5 years, according to the level of education, there are areas of neurodevelopmental growth that are assessed in each group: 5 years, 8 to 9 years, 10 to 11, 13 to 14, and after that, we need to make sure about the transition to adulthood. The psychosocial intervention is looking to address more the feeding practices and the mental status of the caregivers. And these data have been extrapolated by the premature babies and the care that has been given to them. So there is this congenital heart disease intervention program. There are randomized controlled trials addressed to the patients in the context of the school. And then there is another module added to that, which is the Congenital Heart Disease Intervention Program family. So far, the results have been conflicting, but we need to move forward and implement our practices to the adolescents and to the transition to adulthood, where the data are much more scarce, if not absent. So what are the challenges? First, the challenge is to implement those things. And this is a study that has been published in Journal of Pediatrics 2016, so 4 years after the publication of the guidelines of the practice parameters in the circulation paper, which showed that they contacted providers that take care of patients with CHD, and they found out that only 21% of providers were aware of the guidelines, and only 7% received guidance from a pediatric cardiologist regarding neurodevelopmental screening in children with CHD. Moreover, there is a reluctancy from the families, which can be due to distance, to referral to a neurodevelopmental specialist that he's not next to their home, so they have to travel a lot to reach that evaluation. It is not covered by insurance. The evaluation might be lengthy, or the kids with the complex CHD might have long hospital stays, and they are less willing to attend to that evaluation too. In Europe, there is the development of the brief developmental assessment. So essentially, this is a tool that has been implemented for practitioners that are not neurodevelopmental specialists, and they can deliver this to kids with preliminary results that are promising, with acceptable sensitivity and specificity. They are reproducible, and it is feasible and accepted even in remote video conferencing. So, in conclusion, what I need to point out is that children with CHD are at risk for neurodevelopmental impairment. There are more of these. We will see more of these during childhood and through the transition to adulthood. Kids with cyanotic heart disease and single ventricle physiology patients are at the highest risk. Early neurodevelopmental evaluation and intervention are very important. The sooner, the better. And physician, patient, and parent barriers remain a source of challenges for the optimization of these outcomes. On this note, I would like to thank you for your attention, and I would like to welcome any questions.